So good morning and a warm welcome to all. At the outset, I'd like to thank AIOS and Dr. Kumaran for this course. I think we have been doing this course for almost 3 years in a row now, and every year it's been getting better and better. Thank you. So my talk is going to be on advanced monofocals, EDOFs and trifocals. The odd man out here is the advanced monofocal because it really doesn't fit into the category of presbyopic lenses. But because these advanced monofocals have been doing very well and creating a lot of sound and giving comfort to the patients, this has really broken the shackles and come into be compared with EDOFs and trifocals, which actually being categorized as the presbyopic rating lenses. So I have no financial interest as any of the lenses mentioned here, and they're only for educational purposes. We have come a long way in which multifocality was first patented by Dr. Hoffer in the year 1982, and there are a lot of developments which happened in terms of the IOL technology and the materials that use, the property of these lenses and the IOL designs. So each company plays into all these parts to bring in new technologies, actually all the same wine in a different bottle. So what they've really taken into account is the chromatic aberrations, the refractive index of these lenses have been played upon to give you different lenses of different technology. The IOL property, the material, the refractive index, the biocompatibility, the glass transition temperature, all these factors really play an important role in giving satisfaction to the patient and ease of the surgeon to implement them. I'm not going to touch into the basics of these multifocality lenses, but just a basic features of what a refraction is. The light deviates when it goes from one medium to another. A diffraction is a single point of light being split into multiple points, and the EDOF technology. The EDOF technology is making a lot of sound nowadays, but it's not a new technology. It has been used in astronomical telescopes and your SLR cameras long before we started using them. So if you could see all the lenses available in the market or the current scenario, these lenses fall into any one of these 7 categories. They could be refractive, diffractive, or combined. So when you offer these lenses to our patients, we basically have to think what gives them the best. So these are the different pictures of how an intraocular lens looks like. Even we are confused. Just imagine how confused a patient could be when you're going to offer these lenses to them. So the current scenario is when a patient is going to come to you and ask for spectacle independence, there are a lot of options available for these patients. The first 5 options are actually not to be used anymore because the bifocal technology is no more called the multifocal, and it has all been replaced by the trifocal. So basically the last 4 points, the 6, 7, 8, and 9 are the options which we can give our patients. An EDOF lens in both eyes, a trifocal, either refractive or diffractive, micro monovision with EDOFs, and micro monovision with advanced monofocal. So micro monovision simply means that you make one eye or the non-dominant eye less a little bit of myopic so that the near vision will be much better, and a dominant eye which is distant dominant. So basically, what are the limiting factors which really prevents a surgeon from choosing these lenses? There are 4 basic factors: dysphotopsia, biometric errors, cost of the implant, and demanding patients. And out of this, the reason why most of the surgeons do not implant a presbyopic rating IOL is because of the dysphotopsia, glare, and halos. Now let's look into the literature, what it says by addressing all these factors. She shortlisted all the studies available in the last 10-20 years using all these lenses. So as you could see, different kinds of trifocals have been mismatched. All permutation and combination have been tried in one eye and both eyes. So these studies have implanted 3 different kinds of IOLs, the Panoptix, Atlaza, and the Epiphysiol. Why these lenses? Because they are the ones which were available in the market long before the other lenses started to come in. The only important thing to note that all these studies gave a good spectacle independence for all the patients, so all of them were very equal. So even the bifocal lenses, when you put in one eye and a trifocal in the other eye, all these patients did have a very good range of vision. There's no complaint with the visual acuity. Then these are another studies where they contribute the light disturbance or the dysphotopsia. But the only difficult thing is that the trifocals gave a very good range of vision, but however, because of the laws of contrast, they had a lot of reading difficulties when the contrast came down. So I had one of my patients who was an advocate who complained of inability to read his old documents inside the courtroom. So the trifocal lenses usually work very well, but you have to take it with a pinch of salt, saying that in dim light conditions they do have a problem. And whenever we try to refract these patients, always make sure that you do a manual refraction and don't rely upon the auto refractometer, because they don't give a good values. And about the correct choice of the IL formulas, no single IL formula is best for a patient. Look at the patient eye and all the parameters and choose what IL formula is best for this particular parameters. Then there's an interesting study which shows that a negative dysphotopsia is more in younger patient and shorter axial lens. So whenever you're going to implant a presbyopic correcting IOL in a younger patient with a shorter axial length, then you have to be really careful. You have to have a lot of chat time explaining the pros and cons. Contrast sensory loss is definitely there in all these lenses, but it is minimal with EDOF lenses and the when compared with the trifocal lenses. So this is another study which compared the angle kappa. So we all talk about the aberrations and the angle kappa, but you should know that the angle kappa, even if it's more than 0.5, doesn't cause any problem in the visual acuity of the patient. Even when you have a large angle kappa, these patients do very well as far as the quantity of vision is concerned. But when you have a large angle kappa, the problem is that they have a lot of dysphotopsia. So when you have a dissatisfied patient who's having a lot of dysphotopsia, go back and look into the angle kappa. You'll find that the angle kappa is more than 0.5, or the chord mu, which is a real technology now. So angle kappa, and the other important thing is that angle alpha could positively predict the outcome of near and distant visual acuity in these patients. So there's another study which showed you about the advanced monofocal in comparison with the EDOF lenses. They did a micro monovision, and it was found that both of them are doing quite well. So this is the MDF chart, which shows that in EDOF, the intermediate is more prominent. In a trifocal, all are good, but to a certain extent, and in a bifocal, the near is much better than the intermediate ones. So this chart actually summarizes, or the defocus curve summarizes my entire talk, which shows that all are quite good, but the enhanced monofocal, the depth of focus is not as good as the EDOF, but these lenses are very safe when you're going to look into a patient who's very demanding or who is an active driver or a younger patient. The trifocals give a good range of vision for all these distances, and they do well in a person who's going to confine to the household and just wants a spectacle independence for the daily routine work. So finally, it is best for you to understand the technology, understand the patient's needs, understand the patient's finances, and then choose what is best for your patient. Thank you.
Thank you, Dr. Kumaran. What is the experience in the enhanced monofocals? Especially, most of them we see they are within 0.75 residual astigmatism. Does that astigmatism 0.75 to 1, where you don't use a toric, what is the effect of the change in asphericity in the enhanced monofocals?
Yeah.
Are you seeing anything? Is it beneficial, or you can manage it?
See, to understand enhanced monofocal, the real terminology is they are non-diffractive spherical lenses. So usually any of these premium lenses, do not implant them when the astigmatism is more than 0.5 or 0.75. I keep 0.75 as the normal limit, because you really have to have a zero astigmatism for these lenses to work, because the presence of even a small amount of astigmatism is going to compromise the quality of vision. The patient is going to complain. And enhanced monofocal lenses, as I showed you in the chart, the depth of focus is slightly less when compared to the EDOF lenses. The only plus point here is that the dysphotopsias are very, very less. So if you want an elderly patient who wants to read somewhere in the intermediate range and want to have a good vision and should not have any dysphotopsias, then probably the enhanced monofocals do well. Certain patients, the young patients, when you implant the monofocal, they have a good range of near vision also.
Yeah, that's the pseudophocic accommodation to some extent helps. Yeah, I think up to 1, if you put a steep axis where you get a 0.3 correction of the astigmatism, say 0.75 residual, I think should be ideal. Thank you, sir.
Thank you, Dr. Kumaran. That was a beautiful talk.